All right, everybody. Welcome back to the GEMS Report podcast. I'm excited to be joined today by Steve Tafoya. So we're going to have a great conversation. I've been looking forward to this for a while. Steve, I'll let you introduce yourself, and then we'll get going on some questions here.
Yes, thank you for that. I'm Steve Tafoya. I'm a critical care paramedic. I've had about 25 years in this profession. I've kind of done a little bit of everything. I've done military medicine, air and ground, and I used to run an ambulance company, and then I ultimately ran EMS for the state of Nevada. With that, I've done disaster response. Just about every role a medic could be in, I've done that.
Well, that's awesome. And you also have a legal background, is that correct?
Yeah, so beyond just being a critical care paramedic, I also have 2 master's degrees. I have one in business administration and one master's of legal studies. So I kind of combine all that, and that really ties back into what I've done a lot at the state point of view for legislation. I've helped draft bills, I helped pass stuff, and help be the regulatory authority for 60 plus permitted agencies and close to 2,500 providers at any time in the state of Nevada.
Awesome. Well, so that's actually a perfect segue into what we're here to really kind of start to talk about today and unpack. And that's the recent bill that was introduced, semi-recent, the Comprehensive Alternative Response to Emergencies, or CARE Act. So what this is looking at is to test some kind of treatment in place possibilities for a Medicare reimbursement model specific to EMS providers. So kind of where I wanted to start with this is to help the listeners and viewers get a good idea of what the process is from here. So this bill's been introduced, and then where does it go from there, and what can we do to help?
Yeah, so this obviously going back to my 25 years in this space, treatment on scene has always been one of the biggest issues of how to do that for reimbursements. And I would say EMS in general, we've never had a great unified voice. And with this bill coming across, there's a lot of different organizations behind EMS, NAREMT, the National Association of Physicians, National Association of EMS Officials. All of these people are kind of getting together and saying, hey, we need something here for this other part. There was a CMS recording earlier in the year, and from them talking about treatment in place. And they basically said, right now, if you look at EMS, about 1 out of every 4 calls are not being reimbursed. And that's, their numbers, I can't quote them 100%. But close to that is out there for how much is looking to expand. I mean, that we're leaving behind on the table. And if you like it or not, at the end of the day, this is still a business. We might call it public safety, we might call it something else. But when you think about this in a hospital and urgent cares, they are still businesses. And to be successful businesses, you have to have revenue lines and revenue streams. And this is where it starts looking to help for that. If you told any other industry that if you were selling shoes, 1 out of every 4 pair of shoes is not going to get paid for, that's not a good business model. And that's what I think they're trying to finally show. And I do think there will be some carve-outs if a bystander calls 911 and you show up on scene and that person says, hey, for this car wreck, I didn't call 911. I think there's going to be some other places. But as yourself and myself, I've done crazy stuff in the back of the rig, on scene, and the patient decides to go AMA at the last second. I've physically, at one point, we brought somebody back and, did a whole ACLS round and everything. And then ultimately, before we got to the hospital, they went AMA. They legally had that decision, and the amount of money, equipment, and resources that community spent to help that person was not reimbursed. So I think there's a lot of those type of stories out there that really need to expand to help the providers or the agencies to get to a place where they can get reimbursement for it.
Yeah, absolutely. I think we've got to kind of break the chains, if you will, that attach EMS to only being able to bill for transporting someone somewhere, because we've become in so many communities, become the gateway to the healthcare system for a lot of people. So we've got to be able to properly navigate them to the right space in the healthcare system, and at the same time, not overwhelm emergency departments unnecessarily for bringing patients there that maybe really need to go somewhere else, or can receive treatment or services that they need where they are without being transported anywhere. And I think that's a lot of what the future of EMS is going to look like, has to look like, especially if we want to be able to talk about increasing reimbursements. I had no idea that 25% or roughly a quarter of the calls just are not paid at all. And the ones that are paid, it's not like they're paid at the full amount that's billed, right?
Yeah, and I mean, yeah, that's where part of it comes in. And that number is probably skewed a little bit. I would say when I ran an agency, it was probably close to about 1 out of 8. But again, we were a third-party ambulance service that was showing up. We weren't an agency where a rig plus a fire unit shows up every time. So that also, like, your numbers in your county also kind of dictate how that looks. So that one might be a little bit heavier there because you had 2 resources responding and then you got no reimbursement for that. So there is some different caveats based off of each agency where it goes. But I think the other part, you hit on a good topic there, is when you look at the one big, beautiful bill, there is the rural grant part out there as well, that each state's getting, or a couple $2 billion to help improve the system as a whole. And why that's important is EMS is actually listed as one of the providers in that space as ways to communicate or work with partners and those. So most of the states had the deadline to submit their initial application, which is only like a 30-page application. It wasn't very big, back to the government. Well, I think it was during the shutdown, so they should have it. But as it's going, the next round, basically what happens is they kind of do a big overarching plan of what they think they can help these rural communities. Now, with that, a lot of input has been put in by a lot of state agencies there that said, hey, not state, local agencies within the state saying, hey, this is how EMS can fit into this box to help. So you mentioned the treatment in place, but it's also looking at alternative destinations. Some states have that in their regulations where you can go to other places. That's not just an ER. Other places don't. So this is a great opportunity to also use this rural grant funding to look at alternative ways to expand the role of EMS. For so long, we've always had this debate of where are we as a industry? Are we first responders? Are we part of public health? Are we part of the hospital system? And that answer's never really been hammered out anywhere. But the nice part with this new passage of this rural grant part, you don't have to fit into a box. You can redesign your entire system for the rural agencies. It doesn't have to just be EMS. The hospitals and the mental health, they are also looking at ways to revamp that. So coming together with those partners, I think is really going to change how the rural medicine looks at it, but then it's also going to push it up towards some of the other places. I think a lot of research, a lot of data is going to come from these as it does their pilot programs to push the needle farther down the road for EMS.
Yeah, absolutely. And I think you kind of hit on something there as to, where exactly EMS exists, whether it's part of a hospital, part of a fire department, and I think it's going to be difficult to put all of EMS into one box, right? Because I don't think we can say that, hey, this one type of EMS system is going to work everywhere. Right. There's going to be different communities that are going to be better served by different types of EMS models. So, I think it's important and imperative that we're adaptive to that and able to respond appropriately and be able to find these ways for agencies to be innovative when it comes to things like this. So, what this bill that was introduced? So Susan Collins and Peter Welch were the 2 senators that introduced this. Now that it's been introduced, what happens? What happens from there?
Yeah, so basically it goes to committees, it gets feedback. It has usually an open period for people to submit comments to say this is great, this isn't great, and from there it starts getting heard. So this is the time too where a lot of I believe, the National Association of EMTs and the National Association of EMS physicians, I believe on both of their websites, they have a place where you can go and actually help support this bill from there directly. And it clicks on a drop down menu of where you live, so it sends it to your national representatives, both at the state and Congress level there, and then it starts getting their support for it. Because obviously, the more support it has on both sides, that's where it goes. So they want to hear from their constituents that this is actually something that they're looking for. So this is one of those areas where it's a great time to reach out. And if you run a fire EMS agency, it's a great time too to reach out to your politicians as well and let them know directly as an agency, because usually you can get a phone call or a physical meeting with them to tell them why this is important to your area. And this is one of those things where when I met with a lot of senators and congressmen and congresswomen, they did not even know that this was something that was going on. You got to remember, when you're an elected official, you're handling all sorts of topics across the board, whether it's road construction to medical, to insurance. So their database of knowledge is not robust across all walks of life there. So this is a great time to reach out to those elected officials and tell them, hey, this is something that that we would like you as the industry to come across and support. And I know when you think about a lot of the players in the states, a lot of the fires associations, EMS associations, nurses associations, those places all carry a lot of weight. And it's a great place to get behind to show that this is there.
So those are kind of like next steps, if you will, or action items, or things that we really need to do. And I know that I have seen those areas on the websites that you mentioned, NEMT and EMSP. So I'll be sure to link those in the show notes in the comments here, so that hopefully everybody can get there and help their voice be heard, so that we can see something like this continue to move forward. I think another area where this potentially has a lot of ability to change things and really be helpful is in community paramedicine and MIH programs, right? And I think that's another area where you have some significant passions, and I'd love to hear how this could impact services like that.
Yeah, so I was in charge of the state of Nevada EMS when community paramedicine first came about in the state here. And it was very interesting to see how much support it had. When it first got, we thought we'd hit a lot of roadblocks, a lot of unions might oppose it. And it was surprisingly where everybody realized this is an issue that we need better support at. And obviously, if you see Nevada, we basically have, Vegas and Reno and Carson City, and then a lot more rural agencies. And a lot of those rural agencies, they are a lot of the frontline providers, but also they are a lot of just the general providers in town. There's a handful of places in the state here where EMS is pretty much the only game in town. There are not physicians in every town in these places. We don't have a lot of hospitals. So community paramedicine here was one that really took on a groundswell here and really got a lot of support because there was stuff. Now with that, Nevada also put in some legislation that actually allowed for reimbursement for it. So there's not every state, just because you pass it as a state level doesn't mean you also get reimbursement for it. So Nevada put in some stuff there as well. It's not, it's better than nothing, but it's not going to be able to sustain the program. Now, I think when you look at mobile integrated health and community paramedicine, whichever area you call it in your region, I think the one part that people need to look at is kind of start with a need assessment. What are you seeing in your community that has the biggest needs where you can have an impact? And usually if you start working with those partners and say it's the unhoused, if you see something there, that's probably an issue that's plaguing the whole area. So it's going to then the partners in that community and saying, hey, what can we do here and help to do that? There's a lot of places where, EMS providers when part of you get your certification in that state or license, you also have other parts. So a lot of states you're actually listed to give, vaccines and immunizations. You can do blood draws. And if you think about the skill set that we have a lot of stuff that is beyond just what is out there. So you can partner, with other places, and you can go out and you can be the eyes and ears, as physician extenders, and go out there and do these skills and drop off the blood for somebody else, and then have it, run down. A lot of EMS agencies also have CLIA waivers for simple labs as well. So it's looking about what your service actually has. And when you start unpeeling it versus just we can only respond to 911, you realize there's a lot of other solutions there. And I tell people when they're thinking community paramedicine, and you see a hospital in your community, and then that hospital then, has an urgent care, and that hospital then has a pediatric center, and then they start having all these other small categories as well. When you're looking at service lines in EMS, this is where it gives you the opportunity. It doesn't have to be the setup the way you think of it today. It's looking at it from a different angle. And when you start reading a lot of the regulations in states, for example, there's a handful of states where to open an urgent care, all it takes is one physician and one nurse. And that's all it really says. It doesn't say how the rest of the department has to be staffed. It doesn't get into that. There are states that do have more robust language on what it is to be in urgent care. There are some states where even the urgent care is not even defined. It's actually just a physician's office, and they just call themselves an urgent care. So it's really interesting when you start reading the legislation, the regulation behind it, and seeing where this goes. Because, again, if you're treating this as a business and you're looking at other service lines, there's other ways to do this. So even to that analogy where you need a nurse and a physician, you already have a physician. There's tons of EMS staffs right now that have nurses on staff. You might meet that qualification. Is it going to be under your EMS permit? Maybe not. But you can go out and get another permit from the state. There's nothing saying because you have one permit, you can't have other permits. You can't have other departments. And I think that's kind of where this industry has to look at it different. There's a few agencies right now that has, social workers riding on ambulances with them, helping with that part. And some social workers in some states, they have a reimbursement that they can do for it. So it's looking at the equation a little bit different. If you told me down the road that we have, EMS providers, instead of having behind their title, it says critical care, and behind it, it says, social worker, that wouldn't surprise me too. So if you're a paramedic dash social worker, this industry is at a place where people are starting to see that it has a lot of opportunities to touch patients in a way that a hospital can't. And they're starting to utilize those a lot more. And research is one area where EMS has really lacked for years, and it's really becoming very commonplace for it.
Yeah, and I think that you really hit the nail on the head there, and that's where we have to, the research has to catch up, and our ability to, analyze data is at a place where it's never been before, right? And that continues to grow better and better. So we've got to be able to capture those data points and be able to look at individual communities and different services that we can do. And I really liked your explanation there of like the urgent care and then a pediatric subspecialty and other different revenue streams that hospitals can find in those service lines, and how you kind of tied that back to EMS. That really makes sense to me now. So I think that's a great way to conceptualize it and really understand what we're, at the end of the day, trying to accomplish. One other thing I wanted to kind of just unpack quickly, a couple of times you said certification or licensure when you were talking. What's the difference between the two?
That's great. And a lot of, again, when you think about EMS, if you count every state, Puerto Rico, DC, Marshall Islands, there's about, 56 different EMS states. And then each one of those are regulated within their own state regulations. And some states designate it as a certification, and because that's what, when you get from the National Registry, that's what you get, is a certification. So some states, when this was developed, that's the language they used. And then there's other states that call it licensures. And there's other states that even have a hybrid where you get a certification, and then to work on a rig, you get a licensure as an ambulance attendant license. So all of those kind of matter when it comes out. And then you look at the compact that's coming out, and they're using the word licensure. But if you read their FAQ page, it says they're using the term licensure as their broad language. It does not mean that that you have a license. It means that you're still defaulting to your state on what your state recommends. So they have a compact license, but it doesn't mean that if your state still recognizes a certification, that's what it has. And I think that matters as we start going down the road. There are more and more agencies that are becoming to 4-year degrees out there. And I think that's going to be one of the areas down the road that you can go look at and see where it's probably changing a little bit to some of those different terms. And, whatever your state uses, that's what your state has. And so that's how come I always want to try to, use both of them when I talk, because I don't want to make people feel isolated, or I don't want to give the illusion that this is across the board, everybody is certified or everybody's licensed. That's not the case. But it is an area where I think it is slowly adapting. And, when I first started back in the early 2000s, it was an issue then. And I think it will be an issue for a while until somebody can come up with a way to get everybody on board for everything. But it's going to be hard because every state that calls it one or the other would have to adapt to match the other one.
So I think, as we've talked about certification, licensure, and, some different things with EMS providers, specifically to like mobile integrative health or community paramedicine, whatever you have in your area, what types of things can EMS providers look to do or maybe aspire for outside of just what they do in an ambulance?
Yeah, this is one area where I think it's really expanding over time here. So we're seeing a lot more just beyond 911. So we're also seeing just agencies that have just a single response unit where it might just be an SUV that responds. But beyond just the 911 system, in general, there are starting to become more industrial medics. So, as you see a lot of rise of these data centers and these, big warehouses, they have a lot of dedicated medical teams on staff. And when you look at a job board recently, a lot of those medic jobs or EMS jobs in general are looking for providers that are not just working on a rig. So you're starting to see a lot more places where people can go and work, which is nice because it increases, job back and forth pay, because now you have competition. You're not just relying on one solo EMS or fire department in an agency region to pay for these providers. So you're starting to see a lot of competition there. And there's a lot of gigs too where remote, we have a couple mines in Nevada where they hire EMS providers to staff the mine response teams. So there's places where you can see providers going there. There's ship medicine as well, where people go work, on boats. So the role is really expanding beyond just 911. And then again, with community paramedicine and mobile integrated health, it gives other places as well where you can, work a 9 to 5. You don't have to be on these 12-hour shifts, 24, 48. So it gives a little bit of flexibility as well. This is one area, again, where each state differs on what they allow their people to do. There are still some states where you have to only work on a rig. And that's where, again, that running a state, that's where to me it comes back to looking at it. It's just because it's a regulation today doesn't mean it has to be a regulation in the future. If the groups within the state wants to change legislation, this is a great opportunity for them to go look at it to say hey, let's go in. We have a good voice. Let's go in and meet with the elected officials and start looking to see if there is a way to get this changed. It opens up to competition for these providers to go look to tons of other jobs that are out there, whether it's, hiking guides that are also EMS providers. There's wilderness. You think about just any place. I always tell people if it moves, it will break. Kind of the same thing here. If it moves, people need to be treated in that area. So the role of the EMS provider here has a lot of opportunity to expand out. And I think, too, you're starting to see a lot of other classes pop up for people to start learning some of these industrial trades, a little bit better, because you're not doing a typical PCR report anymore. Now you need a different charting system in your warehouse. So it's looking at it from a different angle here, but the provider themselves has opportunities now that are more than just working on a rig, which is nice too, because if there's burnout in your agency and you need to take a little break, there's a place to go for, could be the rest of your career. It could be for 2 to 3 years, and you might want to work back on a rig or box somewhere, but it opens up opportunity for people.
Yeah, I think that's amazing, and especially what you kind of hit on there at the end. If it's scenario where somebody's looking to step away, maybe from traditional clinical EMS practice for even what is just a break and a time to kind of refresh themselves and reset the batteries, if you will, and kind of be able to prepare ourselves mentally to have a continued long, successful career. So I really appreciate you coming on with me today. And this has been a great conversation, one of, I hope, many that'll be coming up. I was just really excited to have you. And any parting words as we kind of round this out?
I think the biggest thing for me to take away as a former, state regulator that people need to look at is, there's a lot of ways to improve this industry. And most of the change will come from the street level up. People then talk to the agencies, and then the agencies have a way to start looking with, associations in their state to start pushing the needle. And that's where, to me, this area has an amazing opportunity. So, we mentioned a lot of the organizations out there, and the nice part is it feels like when the last couple conferences I've gone to the last couple of years, it seems like they were more in line now. And they are looking to really push the industry before. I'm not saying that like 10 years ago everything was in these silos, but it kind of felt that way. And now you can start seeing them pushing them to get everything together. So now the EMS voice is becoming louder, and it's becoming more prevalent in agencies, within the states. So there is a great time to go and look at something. So if there's a bill that you're missing in your state, go look at it. And then with other agencies and other states, there's ways to go look at, their legislation to see, does this sound better than than we have in our state? And that's where change starts. So I think, to me, that is one area where I'm very passionate about, is looking at, the future. And EMS is at a place where it has a great opportunity to grow. And, I think to some regard, we've always talked about not knowing where it lives. And I think that's a great thing as we're moving forward, because it doesn't have to live in this square box. If you don't like the way that it's going, help push that to that direction to give people opportunity to do other things.
Yeah, and that's a great point you made right there, kind of at the end. I think it allows EMS to be more adaptive and more mobile, and be able to do what we need to do to meet the needs, the emerging needs, and the changing needs of society as as we continue to grow and innovate. So, again, thank you, Steve, so much for your time, and I'm sure we'll be having you back again soon. But appreciate it.
We'll look forward to come back on. I appreciate your time.